Hello and welcome to X-ray interpretation for the nurse practitioner. Two-part series. This is part one, and so let's get started. So just a few principles before we start. X-ray or any kind of imaging cannot replace thorough history and examination of the patient. So I like to say, when all else fails, examine the patient. I've had a number of cases in which the imaging was unrevealing. But if you really went back and looked at the patient, took a good history, it really did become much easier to make the diagnosis. So always keep that in mind. Before you order a test, you've got to be ready to deal with the results of that test. That doesn't necessarily mean that you'll have to treat something, but you do want to make sure that you're not doing unnecessary testing that's not going to change anything that you do. Sometimes you'll order a diagnostic test just to reassure yourself or reassure the patient that there isn't something seriously wrong. But be careful. Try to not be penny wise and pound foolish by not ordering tests that need to be ordered, but also just make sure that you're careful. So, make sure you ask yourself, how will this change the care of this patient? It is very tempting to order diagnostics. As a friend of mine used to say, you never get sued for the test that you ordered. You always get sued for the test that you didn't order. And so it is very common that people will order diagnostic tests just to cover themselves. But keep that in mind and try to use imaging judiciously. The other major principle that I think is really important is that closed fractures are very different creatures from open fractures. Open fractures essentially need to go to the operating room, be irrigated, and oftentimes open reduction and internal fixation to prevent the chance of osteomyelitis or some other serious complication. Closed fractures in general, if you can immobilize them, can wait not only hours but even days before they're seen by an orthopedist and addressed. Depending on what your availability is, sometimes it's nice to get them addressed and get them taken care of more quickly. On the other hand, sometimes it's just logical to splint them up and wait a couple of days. Lots of times, depending on what the issue is, it makes sense to let the swelling come down, but just keep in mind that if a closed fracture is truly closed, the urgency is much less. So we're going to look at some films in the following slides, but we're also going to think about what the report would be and how you use those reports to guide care. I think this is more important in other images such as CAT scans, MRIs, and the kinds of things that most of us don't look at ever. But even with x-rays, when we talk about a Jones fracture, for example, the important thing is going to be knowing that those are likely to go non-union and that they are a difficult fracture to treat, as opposed to really exactly being able to recognize a Jones fracture on x-ray, when in most situations for the nurse practitioner, your x-rays are going to be overread by a radiologist at some point anyways. So if you really are in a situation where you really do need to have true interpretation skills, then obviously you're going to be in a situation where you have a mentor, you have some time. The other thing that you can do is there are lots of x-rays online. If you just do a Google image search for a particular type of fracture, you can easily see what that fracture is and get an idea of what the issues are for the treatment of that patient. So let's start. 28-year-old woman, she's had a cough for 6 weeks or so. She had been seen at the walk-in previously. She had a Z-Pak. She wasn't getting any better. She really would like to keep her costs down because she has a $5,000 deductible. So what's our new differential? Well, lots of different things. 6-week cough, you've got could be a bacterial infection like a bronchitis. It could be a walking pneumonia. It could be pertussis. It could be GERD. It could be allergies. It could be some other kind of mechanical irritation, could be a psychogenic cough, so a number of different things. When you examine this patient, there's really not anything to hang your hat on. There's not a lot to figure out. In this particular case, the clinician seeing the patient talked it over with the patient and decided that the idea of a chest x-ray was probably useful. The chest x-ray actually does show some pretty dramatic abnormalities. So if we look at the chest and see that take a strategic approach to it. So we see that the gutters are actually pretty good. There's no blunting here. We follow it around. We see that there's markings in every area. So there's no sign of a pneumothorax. We do, however, see that there is pretty substantial widening of the mediastinum here. That is an abnormal finding, and unfortunately it can be a rather ominous finding. So that in this particular case, we got this woman evaluated by CAT scan very quickly to try to confirm or dispute some kind of a lymphoma. And in fact, she was diagnosed with a lymphoma. So always keep in mind that you're looking at the entire x-ray. You're not just looking for pneumonia or heart failure. When you have an abnormal finding like this, in this case, the radiologist actually called me and talked it over with me. But if you had this abnormal finding, you could also ask the radiologist to look at it. Most of us are in a situation where there's a PACS system, so even if you're in a remote site, the radiologist can take a look at it. All right, another case. Relatively common history, 25-year-old woman. She fell backwards onto her wrist. The terminology for this is a FOOSH injury, or fell on outstretched hand. FOOSH injuries are notorious for certain types of injuries. So if we look at this particular lady, we can see that she's got some pain. She's got definitely some swelling. Happened today. It is noted, it says moderate pain, but it is noted as pretty painful, and she's definitely got a 2+ swelling there. Some people in this case would just order a wrist x-ray. And if you order a wrist x-ray, you're going to see, there's not really anything particularly dramatic here. We look at the distal radius here, not dramatically displaced. There may be a little bit of a line there. The ulna looks okay. The carpal bones actually look okay in this case. But if you're aware with a FOOSH injury, you're going to really check very carefully for snuff box tenderness. And I'll have a picture in a minute of where that snuff box is. And if you have any hint of snuff box tenderness, you need to make sure to order what they call a navicular view. If you get that navicular view, you can see that there is a fracture across that navicular bone. The navicular bone in the hand is also known as the scaphoid bone. You also have a navicular in your foot. If you go anywhere but the United States, it's referred to as the scaphoid. But here in the United States, we often refer to it as the navicular. Some people refer to it as the carpal navicular to discriminate between that and the tarsal navicular. But either way, the problem with a navicular fracture is that they are also notorious for going non-union. They'll often heal separated. If that happens, the patient ends up with chronic pain and ends up needing to have a repair down the road. So as you can see, here's another example of a fractured scaphoid, fractured navicular. That bone, this particular one was actually of a young man who was about 3 months out. And so you can see that this one is actually healed in a non-union position. Because of the pain and because he was an athlete, it was necessary to actually do an open reduction and internal fixation so that he would have less pain and better function of that wrist. So you can see here on the right-hand side where the hand is, where the anatomic snuff box is, right there, just proximal to the thumb. And again, there's a picture of where that scaphoid fracture or navicular fracture usually is. If you have someone that has a question of a navicular fracture, they really need to be in a thumb spica. So this is an example of a thumb spica cast. Many of us know how to make thumb spicas out of orthoglass, and we can make a temporary splint as well. If you don't know how to do that, then this patient really needs to be splinted, fairly soon after the diagnosis. Again, the more that fracture site moves around, the more likely it is to go non-union. So you do want to get it immobilized as quickly as possible, and then have them follow up with orthopedics. So another situation in which you might not necessarily think of imaging, but here's an option for you. Got a 9-year-old girl. She comes in. She's got some belly pain. Hasn't moved her bowels in what she says is 3 days. Now, this age group, it's kind of hard because they usually go to the bathroom by themselves. So if you have a history of that, it could have actually only been 2 days, or it could be 5 or 6 days. That's one of the really hard things about it. So if you have that history, this young girl has no fever, no chills, and one option is to just get a flat plate of the abdomen. And so in this case, if you look at this flat plate of the abdomen, you can actually see here in the rectal area there's a large amount of stool there. You can see some stool as well here. You can see some air going across in this upper part of the colon here, the transverse colon. But the big issue is this large amount of stool that's right here in the rectum. Unfortunately, that usually does require a pretty aggressive laxative and or possibly a little fleet enema or something. It is not unusual to see this pattern in kids, especially 6-year-olds who are just gone off to school for the first time, just because they will hold their stool while in school, and then they kind of lose that sensitivity to the stretch of the rectum, and they end up with these, large stool impactions. If they start soiling themselves in between, having some leakage, large stools that clog the toilet, then you start thinking encopresis. But there's a lot of folks that are sort of short of true encopresis that do have substantial constipation. And I find it helpful to do the x-ray and show the mom or dad and the child, yes, you really do need to be aggressive with some Miralax, with some kind of a bowel regime, just because it's something very concrete that they can see, and they usually will follow up more predictably, I think, if you've shown them that. But obviously it's a little bit of radiation. You're not going to do it unless you have to, but it can be pretty helpful at times. So here's a 22-year-old woman. She felt a pop in her shoulder, very painful now. She can't move it. This was associated, she was a waitress and was actually carrying a really heavy tray, and kind of slipped, and the tray fell, but she felt the pop as the tray went down. About 2 months ago, she had something similar. She went to the emergency room. X-rays were negative at that time, and she'd rather not have x-rays again if she could avoid them. On the other hand, she's having a lot of pain. So in this x-ray, we can see that there is maybe a little bit of displacement away from the glenohumeral joint here. So the glenoid fossa right there, this humerus seems to be maybe a little displaced. Usually there's other views though, and the nice thing in this case is we can see in this view that this humerus is clearly displaced. You can see pretty well that this is an anterior dislocation. Dislocated shoulders have to be put back into position. Most of us are going to send this woman to the emergency room. You know, it would be rare for most people to want to do that, just because if you do put a shoulder back in, rarely when you put it back in there's some vascular compromise. So you do have to have some idea of how to address that and how to maybe get it back out again. But in most cases, it'll pop back in. And to be honest with you, in the many years that I've been practicing, I've never seen one have any vascular impairment. But it's something to think about. If you're out in the willy wags and you really have to get it back into position, what most people will do is have this patient lay on a table, hold a heavy weight or tie a heavy weight to their arm, wait till the weight fatigues the muscles around the shoulder, and then that shoulder will just pop back into position. Even though you've pulled the stress anteriorly, it will fatigue those muscles and it'll pop back in. But and you can see again that with the position here. So a common thing that people don't understand is that a separated shoulder is dramatically different from a dislocated shoulder. A separated shoulder is actually a separation of the acromioclavicular joint, that AC joint where the clavicle comes into the acromion, which is the upper part of the shoulder blade. And depending on how much stretch there's been on that AC joint, then the treatment for a shoulder separation will be pretty substantially different. So again, a dislocation is going to be a dislocation of this joint down here, the GH joint, the glenohumeral joint. The AC joint up here is sometimes displaced. Grade 1, it's going to be stretched. There is going to be no change on x-ray. You're not going to be able to see anything on x-ray because it's going to basically still be in position. It's going to have stretched and then gone back. Grade 2 is it's stretched, had a little bit of a tear there. Again, grade 2, rarely you'll see anything on x-ray. Sometimes what people will do is actually have the patient hold some weights, and that will put enough stress on the joint that a grade 2 will usually show up on x-ray. Grade 3, oftentimes there is some upward displacement of the clavicle, and you often can see that. Grade 3 is a more serious injury. There are grades 4, 5, and 6. Those are usually pretty obvious injuries and usually have complete tear of the ligaments, and so usually do need surgical repair. As you can see, there's been a tear of some of the ligaments here in a grade 3. Those patients have a lot more pain, a lot more discomfort. On x-ray, you can see the upward displacement of the clavicle here. So it's just really out of position. This is one of those things that you need to look at a lot of shoulder x-rays because there usually is a little bit of difference in the height of the clavicle and the acromion. But once you've seen a lot, you'll have a sense of what the normal variation is of those kinds of displacements. So the next case, so a 69-year-old guy, he was feeding the horses, and one of the horses basically kind of put him right up into the trough. His oxygen saturation is 96%, his lungs are clear. Basically he's complaining of a lot of discomfort in his chest at this point, hard to take a deep breath because he has so much pain, and he thinks he might have broken a rib. So what's on your differential? Well, it's possible he has broken a rib. It's possible he's bruised a rib. And the more serious thing is that if he's broken a rib, it's possible that the rib has actually poked a hole in his pleura, and he's actually got a pneumothorax there. So what are your imaging options? Well, if he has mild pain, he has good breath sounds, he's not going to be scuba diving or flying in a plane for the next 6 or 8 weeks, you could get away without imaging at all. On the other hand, if you're worried that there might be a pneumothorax there, then you're probably going to want to at least get a basic chest x-ray, a PA and lateral chest x-ray. If you're really trying to figure out whether there is a rib fracture, for most rib contusions and rib fractures, your treatment is going to be pretty similar for the first couple of weeks. You're going to give them pain medicine, you're going to keep an eye on them, make sure they don't get pneumonia. I really emphasize to people that this is not the time to be the hero and not take the pain medicine. The problem is that if you don't take pain medicine, you're way more likely to get pneumonia. So, you'll have these people that are like, I don't do narcotics. Well, that's your choice, but the risk of pneumonia is substantially higher if you don't control your pain. If you have someone, especially if they're 2 weeks out, they're still having a lot of pain, you're really trying to figure out whether they have a rib fracture, then a full rib series is an option. A full rib series does include a PA chest, PA posterior, anterior, shooting from the back towards the front, and a series of 4 or 5 other films at various angles looking to see whether or not there is evidence of a fracture. So way more likely to pick up a fracture on a rib series than you are on just a basic chest x-ray. In fact, a chest x-ray often misses rib fractures. On the other hand, if all you're trying to do is make sure they don't have a pneumothorax, chest x-ray is a reasonable option. So here's the PA. You can tell it's a PA because in an AP, just based on the angle of everything, the heart looks much larger than this. The heart looks very oversized on an AP. Always, if you have a stationary x-ray machine, they'll do a PA. APs are really only done with portable machines just because of the practicalities that you really can't get a PA in that situation. So if we look at this patient, we see that the gutters are clear. We see that if we run the margin of the heart, we're not seeing any blurring of that margin, so there's no evidence of infiltrates or problems. If we run the entire border of the x-ray, we see that there are markings in there. There's not just plain black. There's no line of black and then a little bit gray with the markings, which is what you would see with a pneumothorax. So this is actually a all clear chest x-ray, no sign of pneumothorax. I don't see any fractures there, but oftentimes fractures again are very difficult to see. Chest x-ray on a rib series, however, you can actually run the ribs down. You may actually be able to pick up a fracture. Personally, I don't even look at rib series when they're done, just because so often when the radiologist looks at them, this is the x-ray I'm overread on the most. So to be honest with you, I almost never even look at them, and I just wait for the radiologist's report. The radiologists are really good at seeing rib fractures, whereas most of the rest of us don't see them anywhere near as well. So here's another view that you see, and you can see, I think in this case right here, there may be a little bit of a displacement there, but again, I'd wait to see what the radiologist had to say. So if you have somebody that has rib contusion and they need pain medicine beyond 2 weeks, it does raise the question of whether or not they really should be getting it. If you have somebody that truly has a rib fracture, then you're probably going to want to have them have pain medicine for anywhere from 4 to 6 weeks. So it can be pretty helpful to try to decide how to manage rib fractures. So, and the last case for this section is a 31-year-old woman. She's breaking up a dog fight. This happened 3 days ago. Her finger is really just a bit swollen. It's actually a bit red. When you do the x-ray, however, you see that there is a fracture right across that what seems to be kind of the mid shaft of that fourth finger. It's particularly important with finger fractures to identify whether or not it involves the articular surface. Because if it doesn't, and it's not grossly out of place, then to be honest with you, you can buddy tape them, you can leave them alone. A lot of patients will say, well, it's just a finger fracture, it's just a toe fracture, why do I care? Well, you do care if it involves the intra-articular surface and it's a joint that you really do count on to have some motion in it as far as function. Just because if it involves the intra-articular surface and then it heals in a way that decreases the function, that can be a dramatically impairing injury. Now, for most of your toes, for your great toe, yes, it's very important to decide whether or not there's a fracture because you constantly use that great toe for balance, for movement. Second, third, fourth, and fifth toes, obviously less important. Hands, I think it is always useful to x-ray if there's any question of a fracture. Looking on the lateral, we can see the fracture here as well, but we can also see that it's basically non-displaced. So that in this case, I think it's totally reasonable to buddy tape this patient for a couple of weeks. That's what we did with this lady. We buddy taped her for about 3 weeks, x-rayed to make sure there was callus there. It was calloused and she was healed. On the other hand, buddy taping her and sending her to orthopedics is not unreasonable. I do think that especially if you're in a place that it's harder to access orthopedics, it may not be necessary and you may want to just manage this fracture yourself. But it really is a judgment call depending on what you have available for services and where you are and your overall comfort level in regards to dealing with these kinds of injuries.